Hello. We will be discussing about the different types of cerebral revascularization procedures that we have been using in the treatment of stroke in our patients. Stroke is the second most common cause of death in our part of the world, higher than any communicable diseases. This was a very common scenario in our hospital where the patient would land up with a large stroke, and the only thing that we could do was perform a large decompressive hemicraniectomy in order to save the patient's life. So in patients who come to us within 4.5 hours of onset of stroke, we started IV thrombolysis using injection alteplase. Here are some illustrations of patients who had undergone IV thrombolysis. And the one on the left was a 73-year-old male who came with a moderate stroke, and we were able to perform IV thrombolysis within 3.5 hours of symptom onset. And he was discharged home after 72 hours with full neurological recovery. There is a big subgroup of patients who have carotid disease, as shown in this blue circle, where the patient had severe carotid stenosis and recurrent stroke. In young patients, we perform carotid arterectomy, where the arteries are exposed in the neck. This video ICG shows the obstruction in the flow of blood. The arteries are first clamped carefully, starting from the ICA, and then the common carotid and the internal carotid is sharply opened. Here, the thick atherosclerotic plaque is being carefully dissected off of the intimal layer of common carotid and internal carotid artery. The plaque is sharply cut off from the common carotid, and the intimal layer is washed with heparinized saline, and free-floating plaques are then carefully removed. Then the artery is sutured using running suture, a black flow is checked, and finally the artery is closed, and the clamps are carefully removed. The video ICG shows good flow in the arteries. This is the patient on the first postoperative day, and these patients are usually discharged home on the second or the third postoperative day. Unfortunately, many patients with carotid stenosis deny any treatment. Here is an example of a young patient in his early 40s who had severe carotid stenosis but refused any treatment and later landed up in the ER with massive infarction involving his entire internal carotid artery territory. Now, there are some conditions where the patients may benefit from flow augmentation of cerebral blood flow. In this young child with right-sided hemiparesis secondary to recurrent stroke, the MRI shows severe gliosis involving the left MCA territory. With the diagnosis of pediatric moya-moya disease, we took the patient off for bile synangiosis. With the superficial temporal artery marked, the artery is carefully dissected free from the scalp using sharp dissection. The side branches of the artery is carefully coagulated under low bipolar setting. The artery is being dissected free along with its adventitial layer and is finally freed from the temporalis muscle. The temporalis muscle is then split in a cruciate fashion, and the temporalis muscle is elevated to expose the bone. Two burr holes are made, and the craniotomy flap is carefully elevated. The dura is again opened in a cruciate fashion, and the arachnoid layer over the brain is sharply dissected free. Then the artery is sutured using a Teno nylon to the pile surface of the brain. Hemostasis is secured, and closure is done carefully to prevent any compression on the artery. The post-op CT angiogram shows the course of the parietal branch of the STA along with the flow in the distal segment of the artery beyond the craniotomy. This was a lady in her mid-40s who had history of recurrent stroke, and when she presented to us, she had severe speech difficulty. We went for a direct cerebral bypass, and here the recipient M4 segment of MCA is being dissected. The STA is then prepared, and the adventitial layer is stripped off. The end of the STA is open in a fish mouth fashion. The recipient is then opened, and first we start off with the heel suture, and the heel end of the anastomosis is tied off. Then we suture the back wall of the arteries in a running fashion using Tenno suture, and at the toe end of the suture line, the sutures are then tied off. We then check the luminal surface of the anastomosis, and the front wall of the arteries are then sutured again using Tenno suture, and then the hemostasis is checked and flow is checked with ICG, and the wound is closed in standard fashion. This is the post-op CT angiogram showing the direction of new added blood flow and the anastomosis in the circle. Cerebral DSA performed 7 years later shows patent bypass perfusing the MCA territory, and clinically the patient has had no new strokes and her speech has completely recovered. This is an example of a double-barrel bypass, wherein the frontal branch of the STA has been used to perfuse the frontal lobe, shown by the blue circle, and the parietal branch has been used to perfuse the temporal lobe, shown by the green circle. This is a one donor, two recipient variant of STA-MCA bypass, where an end-to-side bypass has been performed on the frontal side, shown by the blue circle, and a side-to-side bypass has been performed on the temporal side, shown by the green circle. In this patient with recurrent stroke, the angiogram shows absent internal carotid artery and no viable donor site from the external carotid system on the side of the stroke. Here, we performed a bonnet bypass. The saphenous vein taken from the leg has been anastomosed with the STA on the opposite side, and the vein has been taken across the calvarium to perform a end-to-side bypass with the M2 segment of the ipsilateral MCA. Now, at times, we replace the normal cerebral blood flow through a bypass for the treatment of some complex cerebral lesions. This patient presented with an unruptured fusiform aneurysm involving the right middle cerebral artery bifurcation, for which microsurgical clipping or endovascular options were not feasible. Under very high magnification, the Sylvan fissure was split using a combination of sharp and blunt dissection. The branches of the MCA were checked, and a large vein in the Sylvan fissure was carefully preserved using careful dissection. Then a direct STA-MCA bypass to the M2 segment was performed, and here the MCA aneurysm is being carefully dissected and extended towards the proximal segment. Once the healthy segment was identified, a temporary clip was placed across the MCA just proximal to the aneurysm, and flow was confirmed with ICG. Then the temporary clip was replaced with a permanent clip. The post-op period was uneventful with no neurological deficit, and follow-up CT angiogram showed complete occlusion of the aneurysm from the circulation. We have been operating on a large number of complex cavernous sinus lesions, often deemed inoperable. This lady in her 70s presented with a history of sudden onset of left-sided ophthalmoplegia, and CT angiogram showed a large fusiform aneurysm involving the cavernous segment of left ICA. A radial artery bypass was performed between middle cerebral artery and the external carotid artery in the neck. The ICA was clamped in the neck, and flow across the bypass was checked using video ICG. Once the flow was confirmed, a permanent clip was placed across the ICA just proximal to the origin of the ophthalmic artery, and the ICA in the neck was tied off to completely wrap the aneurysm. The post-operative period was uneventful, and on 6-month follow-up, the patient had persistent lateral rectus palsy despite the angiogram showing complete occlusion of the aneurysm. This patient was previously treated elsewhere for a lacrimal gland sarcoma and was then sent to us when she had recurrence in the cavernous sinus. The cavernous sinus lesion was successfully removed by us. 3 years later, the patient came back to us with a very ugly recurrence of the tumor. This time, the tumor had completely encased the internal carotid artery and had caused invasion of the brain parenchyma. We performed a right-sided radial artery bypass followed by complete exenteration of the cavernous sinus to achieve a gross total dissection of the tumor. Postoperatively, the patient had no new neurological deficits and was sent for radiotherapy. With the recent advances in the field of endovascular therapy for cerebrovascular diseases, we have started endovascular treatment for selective diseases. This patient presented to us 7 hours after the onset of acute stroke, and we took the patient off for mechanical thrombectomy and achieved a good cerebral revascularization. This patient presented to us 17 hours after the onset of stroke, and with a good aspect, we performed mechanical thrombectomy and were able to achieve a good outcome. This comatose patient due to intracerebral hemorrhage secondary to cerebral venous thrombosis was referred to us. We performed a venous mechanical thrombectomy and opened the occluded left transverse and sigmoid sinus. Patient made full neurological recovery. We have achieved good clinical outcomes in patients with cerebral vasospasm secondary to aneurysmal subarachnoid hemorrhage using intraarterial vasodilators. In elderly and morbid patients with carotid artery stenosis, we have been using carotid artery stenting to open the occluded vessels. This patient had sustained injury to the neck and had developed stroke due to a pseudoaneurysm in the internal carotid artery. We performed carotid artery stenting to reduce the chances of future stroke. This patient has sustained injury to the right vertebral artery during an anterior cervical surgery outside Nepal and had developed a pseudoaneurysm. We did a vertebral artery stenting to exclude the aneurysm from the circulation. We feel that endovascular therapy has been a game changer in the treatment of complex diseases like carotid cavernous fistula. In this case of CCF, we performed coil embolization of the nidus of the CCF to achieve good clinical outcome. As high as 30% of mechanical thrombectomies fail to achieve good revascularization. In these patients, there is a scope of performing emergency bypass to salvage the brain. To conclude, we strongly believe that neurosurgeons should get more involved in the management of acute stroke. Thank you.